I'd like to talk today about the intersection of COVID and critical race theory by focusing on public health critical race praxis. And I come to you from Southern California on lands originally inhabited by the Gabrielino Tomba peoples who also cared for it, and I want to make that acknowledgement. What I'd like to do today is first characterize racism in the early 21st century during this COVID pandemic, define equity and racism in ways that I think are particularly useful for thinking about critical race theory and health inequities from the sort of praxis orientation, introduce public health critical race praxis, and focus primarily on the social construction of knowledge, which is an aspect of public health critical race praxis that this praxis is concerned with. And I'll close by posing what I believe are urgent questions for the field. So to start, there were between the 1-year period, March 1, 2020 and March 1, 2021, obviously dramatic increases in the number of COVID diagnoses and deaths, totaling slightly more than 500,000 US residents who had died during this period. And from the beginning, there were a number of data issues. And those data issues include the failure of health departments and others to collect or report data by race and ethnicity, so the outcomes by race and ethnicity, reporting of race and ethnicity data for some COVID outcomes, but not consistently for all COVID outcomes, missing data on race and ethnicity, and at the time, no state reported race and ethnicity data for 100% of those outcomes. And this persistent issue of the other race or ethnicity category. And I take these snapshots from California and Hawaii in order to just illustrate these points. So we can see that the percent of cases, deaths, tests, and hospitalizations that include data on race and ethnicity varies across the categories. This information also varies between the states, with information missing completely on race and ethnicity for hospitalizations in California, whereas some data are available on hospitalizations in Hawaii, but not on testing. This gives you a sense of the kinds of uncertainty with which we were all dealing. Once data on race and ethnicity did begin to become available, it was clear that racial and ethnic disparities were ongoing. So these data, which are from March 7th, 2021, indicate that African Americans and Black people were dying at a rate of 178 deaths per 100,000 people, in contrast to whites who were dying at a rate of 124 per 100,000 people, 100,000 population. This chart also shows us that the tendency, how we organize groups matters. We often categorize Native Hawaiian and other Pacific Islanders along with Asian populations. And here we can see that there are actually stark differences in the rates of death for those populations. And the burden of disease among Native Hawaiian and Pacific Islanders is obscured by that grouping. So these issues matter because they're issues of equity. And on March 16th, 2021, 1 year after the real start of the pandemic in the US, the COVID Task Force on Racism and Equity published a blog really saying, we told you so. We told you that disparities were likely to occur. And the purpose of saying we told you so was not to be flippant, but to be clear that there are ways to identify and predict, and thus to potentially prevent stark racial and ethnic inequities, but it really starts with being able to perceive, understand, and appreciate the ways in which racialization operates in the early 21st century. Equity has been defined by former president of the American Public Health Association, Kamara Jones, as assurance of the conditions for optimal health for all people. To achieve equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustices, as well as providing resources according to need. And I hope that what you hear here is that equity is, at essence, not an outcome, but an action, a process. My work has largely drawn on critical race theory to try to pursue equity and engage equity. The founder of critical race theory, often called the father of critical race theory, Derek Bell, advises that the racial philosophy we must seek is a hard-eyed view of racism as it is. In doing this work, racism has been defined as a system of structuring opportunity and assigning value based on the social interpretation of how one looks. You can hear that US-centric understanding of racism here. This system unfairly disadvantages some. It unfairly advantages others. And as a consequence of this, the strength of the whole society is wasted, the resources of the whole society, human society, of the whole society are wasted. This is a definition offered, again, by Kamara Jones in her capacity as president of the American Public Health Association. So this is widely used within the context of public health. However, the social geographer Ruth Wilson Gilmore offers a different definition widely used by critical race theorists. This definition is, racism is the state-sanctioned and or extra-legal production and exploitation of group-differentiated vulnerability to premature death. And on its surface, this definition may seem largely disconnected from the work that happens within epidemiology. But in fact, I believe this definition can be really an important compass in guiding epidemiologic work to be anti-racism focused. Here we can break down this definition into the source of the problem, state-generated sources, as well as those external to the state. Mechanisms include those that produce conditions of inequity, as well as those that exploit conditions that are already in place. It has a clear population focus rather than, for instance, the type of interpersonal or individual level focus that so many racism definitions have. Clearly, the use of terminology like vulnerability emphasizes the implications around risk. It emphasizes the need to consider risk factors, even perhaps. Vulnerability to premature death. We know the road to premature death is paved with morbidities. And so here we have to think about this definition as being tied to the body. Again, mortality and premature death indicated here. And so this definition is useful for anchoring an understanding of racism as inherently tied to the physical body and to populations. It's important to think racism persists over time, and therefore it's important to understand how it evolves. It is able to persist because it evolves and fits within the new and emerging social and political contexts. We clearly see the ways in which overt forms of racism are existing in our society today, hate crimes and hate incidents, for instance. However, the dominant mechanisms by which racism operates are less perceptible. And that is a key characteristic of racism in the early 21st century. That is, that racism operates in ways that are difficult to perceive. and that the overt mechanisms are tied to these less perceptible, but more structural and influential mechanisms. In addition to the myriad of ways in which we see or can study racism operating in the early 21st century, there is also a growing readiness for anti-racism work, both within the field of public health, within EPI specifically, and also in society. And we can gauge this in part, for instance, by funding opportunities that are available today that have not been available in the past. And there are also growing bodies of evidence around the health implications of racism. And this work is important because it documents the ways in which racism, specific mechanisms by which racism actually contributes to health inequities. However, if we are going to move to a new page, one where equity reigns, then we have to move from conducting research on racism solely, that is the pure goal, toward conducting anti-racism research. Anti-racism is a commitment to dismantle racism across all socioecologic levels. So here we're talking about active engagement and something that undoes the structures and systems that enable, let's call it the automation of inequities, the sort of perpetuation of inequities. Anti-racism research challenges racial research directly. It studies what marginalized communities identify as priorities. And here we might think of this as centering those perspectives, centering the starting point for research in the margins rather than in the mainstream. And it necessarily generates new theory and methods in order to advance the work. Critical race theory can be understood as an anti-racist intellectual movement that originated in law in the late 1980s, early 1990s. It originated as such, as formally named critical race theory in law, in order to identify, understand, and undo the root causes of racial hierarchies in the post-civil rights era. This is an era characterized by an overt sort of embrace of equity, and yet persistent inequities that occur particularly through institutions and systems. So the goal is not merely to incorporate, for instance, minoritized individuals or populations into existing structures that are flawed and continue to perpetuate inequities. Rather, the goal is to identify the flaws and to address them in order to create structures where equity is possible. That is, that everyone has an optimal opportunity for well-being. As with critical race theory, public health critical race praxis is rooted in a critical paradigm, which recognizes inherent power imbalances and sees a researcher as having an obligation, having recognized or identified some factors contributing to these inequities, as actively working to address them, and which sees this process as rooted in the need to illuminate one's own biases that might shape understandings and the knowledge produced through this endeavor of trying to challenge the existing power hierarchies. In 2010, a little over a decade ago, Collins, Irene-Bua, and I introduced public health critical race praxis as a set of approaches and tools that guide researchers in applying critical race approaches to public health research. And this is important because we wanted to root the strategies and methods and theory and even the interpretation of findings that health equity researchers generate in ways that are organic to public health, and at the same time connected to the robust work happening outside of public health around racialization. Every project rooted in this praxis begins with two questions, which are asked concurrently. The first is, how is racism relevant to this public health problem? And the second is, how does racism influence the production of knowledge about this problem? There are three key elements on which we draw. The first is a racism conscious orientation. Next is a lexicon and set of principles that are largely borrowed from critical race theory and law. And the final is a four-stage semi-structured self-reflexive research process, which I'll talk about very briefly. So this is the roadmap for carrying out research based on the public health critical race praxis. One begins with an intentional racially conscious orientation to the project. That is not to deny racialization, but in fact to intentionally think about the ways it is relevant here. Then to begin to assess contemporary or contemporaneous, in the case of historical work, ways that racism is relevant to this particular project, this particular endeavor. The next focus is to identify biases in the field which may shape the direction or some dimension of the work. And this is particularly important for empirical work, because empirical work obviously builds, it's just, any empirical study is obvious. Well, I'll say empirical models, any kind of work that we're doing, builds on an existing evidence base. And that evidence base therefore shapes, is embedded with understandings that shape what it is that a new study can do in some manner that's responsible to that evidence. And so it's important to acknowledge any potential biases that might influence that, the immediate, the index study. The next focus is to operationalize measures based on these prior considerations, and then ultimately to take some action. Now, certainly it would be irresponsible, perhaps, to take some sort of action based on the evidence alone from one particular study. However, the action that we take can be an action based on the equity engaged process, the community engaged process that we've learned here. So taking action may be taking some kind of action like sharing the findings with community in some particular way that supports their ongoing equity endeavors, but it could also engage communities in sharing learnings about how to do this work. Public health critical race praxis is one way to approach conducting research on racism and health. However, there are a number of other approaches. For public health critical race praxis, to use this model in its entirety requires at least 7 essential characteristics be embraced in a project. That is, the work is based on critical race theory, that it is focused on racism, whether racism is an explicit focus of the study or not, that it is focused on health, that it centers the margins, it draws on the perspectives of those who are outside the mainstream, that it is empirical, again, with an asterisk here, involving empirical and scientific approaches. It is self-reflexive, that is, I, the researcher, recognize that I play some role in helping to shape and socially construct the knowledge. Therefore, I have a responsibility to try to identify what biases I bring to this work, and that it follows, and finally, that it follows a sequential process, the kind that we associate with science. And certainly, if we look at social epidemiology, work on racism and health is widely done with using a social epidemiology frame. However, it does not necessarily require one to base the work on critical race theory, to be racism focused, centered in the margins, or self-reflexive. This is important not to hierarchize different approaches, but to be able to speak with accuracy and validity about the specific types of approaches being used in specific studies. And as we advance as a field in doing this work, doing more sophisticated work on racism and health, this is absolutely critical. So I've introduced public health critical race praxis and talked a little bit about why it's important to think about in the context of the COVID pandemic. I want to just focus a little bit on what people are doing now with public health critical race praxis. Much of the work now is not an entire application of the full method in terms of the empirical method. However, there's a considerable focus on critical reflexivity, disciplinary critique, and as well as trying to center the work in the margins more systematically, and a focus on what it means to speak back to the evidence base, the large evidence base, by what stories we tell based on the data that we have available to us. So I'm emphasizing the social construction of knowledge because, as with critical race theorists and critical theorists more broadly, public health critical race praxis adherents, or health crits, do rather reject the understanding that, or well, I might say the assumption that science is objective and therefore it is inherently bias-free. We would counter that the systematic nature of the scientific method enhances the reliability of empirical findings, but this does not necessarily eliminate the influence of racial bias. And we can see this if we look back to, for instance, the early 1900s and research that was scientific and yet racially biased. As sociologist Larry Bobo puts it, quote, "Data never speak for themselves. It is the questions we pose, as well as those we fail to ask, as well as our theories, concepts, and ideas that bring a narrative and meaning to marginal distributions, correlations, regression coefficients, and so on." And I found that the work of Steve Wing, the environmental epidemiologist, the late Steve Wing, I think the title of one of his papers encapsulates this idea, and his work was really formative for me in asking whose data, whose epidemiology, so that how we approach this work even matters in part based on who's asking the questions. From a public health critical race praxis perspective, there is this sense that the investigator should be reflexive, considering the ways in which I may be shaping the evidence that I am working to understand. And one example of the way we go about trying to do this is from a study I conducted several years ago, the HIV TLR study. This was a large retrospective cohort study based on the medical records of more than 3 million patients enrolled in a large primary care provider within the Southern California region. And our goal was to try to understand both how the neighborhood context in which they live, as well as practice characteristics of the places where they receive care, as well as factors associated with their care provider and their interactions with the care provider, might influence outcomes, HIV care-related outcomes, among patients, all of whom are already in care. And what I want to focus on here today is actually just this process of trying to assess our own a priori assumptions. So what you hear is an assumption that we all have and brought a priori assumptions to the work. So each person on the study team self-administered a confidential questionnaire at key points during this study. And this is not to say that we did not have evidence-based hypotheses guiding the work, but in addition to those, and in addition to the work that NIH was funding us to do, we wanted to capture what kinds of thoughts and assumptions do we bring to the analyses. And so at the beginning of each new set of analyses, each person completed this little questionnaire that was an open item question included open items and liquor type response items to assess what each of us expected the results to be, how certain we were about those expectations, whether we expected to see any kinds of disparities, what our bases for these expectations were. And the truth is that everyone did have, there was no one who came to it with a complete blank slate. And we have only used this qualitatively as a check in order to kind of keep us honest about the investments that we have in the findings that we produce. Other work is looking at not the individual critique, self-critique, individual self-reflexivity, but how can we apply this to our field in a way that helps to keep our field honest about the assumptions and biases that may be embedded in the field. And so Kemi Dole has been doing some work in the area of endometrial cancer and conducted a systematic review, led a systematic review that I was fortunate to be a part of, and really wanted to understand the disconnect between the burden of disparities borne by Black women and the framing of the problem and the approach to the problem within the field. And the main finding, the main result of this analysis, of this systematic review, was that we noticed that a narrow definition of race that emphasizes race as a biological construct, although the researchers would not say that that's what they were doing, but in short, that is what the framing of race is in these studies. That framing appears to result in an underemphasis on the role of modifiable contributors to these disparities, right? So the focus on biological determinism obscures the possibility of earlier intervention. These things are important, in part because there may be ways for us to address these problems if we're using the right tools to identify them. And some of you may know that I have been struggling or grappling for some time with this charge or this concern that Audre Lorde, the Black feminist librarian, lesbian, raised quite a while ago in the mid-20th century, saying the master's tools will never dismantle the master's house. So the question for us is, to the extent epidemiologic tools, the tools of epidemiology reproduce or help to reproduce existing power hierarchies, they may be considered master's tools. The question that I have been wrestling with is, what do we do with that? Are there indeed no master's tools that we can use, or how do we change the master's tools? Those are the kinds of things I'm struggling with. With respect to COVID, one major concern is that of policing and surveillance. The very communities most impacted by this pandemic, Black, Indigenous, and people of color communities, are also already disproportionately impacted adversely, socially, politically, personally, by policing, law enforcement, and other forms of surveillance. And so we have to be thoughtful and careful and maybe very strategic about how we deploy surveillance to address the issues of COVID inequities. We undertook a series of environmental scans to try to assess early in the pandemic exactly how existing COVID surveillance systems, how well they address a number of issues and how useful they are, not only in terms of your standard criteria, such as the usefulness, timeliness, et cetera, but also in terms of some very, very sort of superficial critical race theory informed criteria, including which race and ethnicity data are collected, if any, what kinds of stigma measures are collected. For instance, the hate crimes data are not only data about racism, but they are hate crimes are also operating in ways that tell us something about the stigmatization of groups. which measures of racism, if any, are included, or what measures are included that might capture forms of racism, and then what kinds of harms might these systems produce. And several of the lessons that we've learned, first, that there are racialized power dynamics in the creation, management, and use of big data, that racism is embedded in both the data themselves and in the systems, and that it's important to consider system-specific ways. So for instance, how racism might operate specifically within a particular database, as well as the ways in which it might operate globally across databases. And these power differentials exist between researchers, not just by big data in general, but also there are power differentials in particular made clear during the COVID pandemic and the large amounts of data being generated during this pandemic between researchers and communities, both in accessing data or information, as well as in who can generate conclusions based on any data or information. And this is particularly true when the analyses are very sophisticated. So I return to this question: what is the story and who gets to tell it? And we were really interested in understanding this at the time of the initial rollout of the first US vaccine, and truly of any vaccine. And so we began monitoring state health departments on Twitter. State health departments are tasked with coordinating COVID responses and disseminating accurate information. The question for us is, how did they frame potential low vaccine uptake among Black people during this period? Discussion was ongoing widely on social media and elsewhere at this time. That discussion essentially offered several different options for understanding any future low uptake of vaccines that will become available. One narrative was that due to historical racism and mistrust, African Americans may not be comfortable receiving the vaccine. And so that's a racism-based mistrust framing. Another was that African Americans were simply non-compliant with current recommendations about vaccinating. So this study is based on data that, prospective data collected from October 19th, 2020 through February 28th, 2021, encompassing the date when the initial Pfizer vaccine emergency use authorization was granted, as well as the first vaccine administered in the United States. And we collected more than 36,000 tweets, so 100% of tweets from 100% of US state health departments and the Washington, DC health departments. And this chart shows you what we observed. The gray background is the number of vaccine doses administered during this period. And we have the number of tweets posted by each of the state health departments for these different regions that we looked at by the Department of Health and Human Services region. And the long and short of what we found is that throughout this period, state health departments, first of all, did not tweet for the most part very much at all, which represents a missed opportunity to address what was a lot of misinformation early on, relatively early on in the vaccination portion of the pandemic, and tweets that dealt with COVID at all rarely addressed issues of racism and equity, leaving this sort of void in the discussion about it, which one might argue, at the very least, did not address the narrative that was beginning to dominate and continues to exist, that inequities in vaccine uptake among African Americans may be due to something like non-compliance with existing messages. Very little information on historical mistrust. there's a lot here that we could discuss, but I do want to bring us back to critical race theory. We are talking about critical race theory today, not because it is a dominant approach used in public health, not because it is a dominant approach used in epidemiology, not even because I believe it can be a very useful way to do the work on health inequities. We are talking about it today because in a speech delivered at the National Archives in 2020, then President Donald Trump raised the issue of critical race theory, proclaiming it to be a serious threat to the nation and divisive. And indeed, we now find ourselves in this position where we need to clarify exactly what critical race theory is and how we can, what we must do about it. I highlight this in part to highlight just how important the narrative is. So there are a number of urgent questions. They include, is the mere production of evidence of inequities sufficient to achieve justice and equity? And here for me, this question comes from having watched Black bodies get shot or killed in the streets, having that direct evidence and seeing how long it has taken to produce the kinds of outcomes one would anticipate to have as a consequence of this evidence. Another set of questions have to do with the field's norms. How do they help consolidate white privilege? How do they re-marginalize minority perspectives? How do they model equity? And also, how do racialized assumptions inform research? How do the field's racial approaches inform those of the broader society? And finally, how do power dynamics within the field reveal which perspectives matter and which do not? So in conclusion, causal inference. In conclusion, we will not be able to achieve the kind of equitable society that we desire unless we're able to grapple in more rigorous and comprehensive ways with the ways in which racism operates in the early 21st century. Critical race theory is an extremely useful tool for doing that. And I think within epidemiology, we'll have to rely on public health critical race praxis or some other such tool in order to be able to do so comprehensively. I'd like to make these acknowledgements. Thank you.